This is Ladies Corner with T. Thank you so much for joining us. Tonight, I'm excited to introduce our guest. She's the CEO and founder of Canada HomeCare Group. Dr. Jennifer Njenga has lived and worked for more than 18 years in several countries, including South Africa, Canada, Australia, and New Zealand. Special interest is in primary care, public health, Indigenous health, and maternal and child health. She has worked with vulnerable populations, including seniors, refugees, and Indigenous communities. For more about Dr. Jennifer, please go onto their website, www.canadahomecaregroup.ca. And I say that because your CV goes in pages and it's so overwhelming. It's impossible to go through it. So I just, cut it short and welcome so much, Dr. Jennifer. How are you?
I'm fine, T. Thank you for having me on your show.
You're welcome. And I was just saying, it's impossible. Your website was really overwhelming for me. And look at you looking so fresh. And I'm just wondering if doctors are allowed to look so refreshing.
I think we try with everything else that's going on. We've got to do something, right? We've got to do something that makes us feel as though there is hope. There is hope.
You think so? We're all not going to die in this pandemic. You really
No, it looks terrible and it sounds terrible. And lots of things are happening, and but we need to keep the hope. It keeps us alive. It keeps us alive for sure.
Amen. Dr. Jennifer, once again, you're welcome to Ladies Corner with T. So let's get right into it. You're the founder of Canadian HomeCare Group. What do you do there?
Okay, so Canada HomeCare Group is made up of a lovely team. We have a team comprising of doctors, family doctors, nurse practitioners, nurses, licensed practice nurses, LPNs. And what we do, we provide after-hours care for people in Alberta, all age groups. And so we come to your house to do the house calls. So we come to your house, we're able to come to your house and provide with non-urgent care. We do this virtually, so over the phone, or we come in person. Sorry, T, you saying something?
No, sorry, that was my phone. I'm trying to share so we get more people watching in. I beg your pardon. I didn't mean to.
No, that's all right. That's okay. So yeah, so we do offer non-urgent care. So we offer this care that's 4 p.m. to midnight during the week, and the weekend is 8 a.m. to midnight. So you give us a call on our numbers, or some people send us emails, and then we have a conversation with you first. We do our screening, especially for the COVID. And when we think that things are okay, we do come to the house and give you that care. So basically, it's like when you go into a walk-in clinic, but this time we're walking into your home and providing services.
Now, when I heard that, I was scared. I was like, oh my goodness, how do these people not catch COVID? And in my head, when my daughter in September, she sneezed and they sent her home. And my sister's son coughed, they sent him home. So up to you.
Right.
How do people alive and have a thriving business in this?
Right, in this era. It is, yes, it is challenging, and we really do our screening. So we use the Alberta Health Services screening tool, and we ask all the questions. We ask whether you have a cough, you're sneezing, you have a fever, you've traveled overseas, you're in contact with someone with COVID. Once we're satisfied with your your responses, we can then tick you off as ready to go. We can come to your house. But also when we come to your house, we're quite strict with our PPE. So our practitioners are gowned up. They use the gowns, their masks, their face shields, their goggles. So they practice the necessary precautions.
Oh, okay. Oh, wow, you guys are my number one heroes. You're very brave. One of my friends, her husband is a doctor, and when he comes home, he just doesn't hug the kids and go sit and have dinner. They have a special shower place where he showers first, and he thoroughly disinfects before he joins the family. Do you find that you have to do, you understand what I'm talking
Yes,
about?
we do the exact same thing. We do the exact same things. Once you enter the house, the whole household knows that, you've been out there, you've been exposed, you may have been exposed. So most of our staff have got a basement a shower where they'll go and remove all their clothing. They'll shower and then they can join the rest of the family. Now, the gowns that we use in people's homes, we don't come home with those. We bag them. We actually bag them, and those are ready to go in the rubbish bin. So, for instance, if we're doing vaccinations, we go out and do flu vaccines, or we're giving pneumonia vaccines. We normally our nurses will wear their yellow gowns. They will take those gowns off and the gloves and put them in a disposable bag. And that bag is normally left. Sometimes it's left. Most times it's left at the patient's or the person's home. So the person will go and bag it as well. So
Oh,
we're very, very cautious. Yes, we're very cautious.
okay, and that makes sense. I just wonder, when you go to people's homes, you're in essence going into the community. What are some of your top challenges other than COVID? What is it that you're seeing that you know,
Yeah,
that
I
maybe?
guess
Mhm.
it depends on the community as well that we're going to. I'll talk about our refugee communities. When you enter the home, you find a large family. There are lots of children in the home. And when you look around the furniture, or, sometimes you find that they're eating. When we walk in, we come find they've just finished a meal. Some of the homes, they look dire. You think, there's a lot lacking in the home. It's not your own home where you have a kitchen with cups and plates and spoons and all sorts of things. You can notice that even the stuff they use, their kitchenware, or even the lounges where you might find 2 chairs only or 3 chairs. You have so many children. The other thing we noted when the winter started was the cold. Some of the houses are really cold. We walked into a house. There were 11 children in that home. They're a refugee family, and it was really cold. The carpet was cold, and the father had just gone out. He didn't have a car, so the family doesn't have a car. They don't have cars as well. So they had borrowed a car from somebody. And as we're walking in, we're doing our stuff. We're giving immunizations and following up on the baby. The father happened to come back. A friend had brought him, and he bought a heater, and he placed it in the center of the lounge on the carpet, and all the children gathered round around this heater. And you're thinking, if that's what they have, it's this cold. What about the bedrooms and the bed? So that was really touching for us. The house was really cold. So those are some of the things we notice. Our refugee homes, the families don't have transportation, and they have to borrow cars to go see somebody. And with 11 children, really, if you have a standard car, you can't fit everybody in the car, right? So that's why they give us a call and say, could you come and see us, or could you provide us with this service or the
It
other?
sounds. I'm sorry.
Yeah,
I beg
yeah, no, that's okay. And some homes as well, if the seniors, for instance, if you have seniors, you find that they're struggling to move around, and most times we ask who else is with you. We've been fortunate. We found most of the seniors have a family member who come around often, who's around in the backyard, somewhere in the other room, or is away for the time of visiting. But you find that there's a bit of a struggle. You may find that they've already had their breakfast dishes are where they are. They've not managed to move them to the sink because mobility is a problem. So these are things we kind of notice when we go to the homes.
Mm. I feel genuinely touched by what you remember or what you see when you go in the community in some refugee homes. And I'm wondering, are you able to refer them on? Because I just feel it's wrong that you be in Edmonton, where there are so many resources for refugee families, for immigrant families. There's actually a budget for refugees in the city, and people still live like that. So,
Yeah.
do you pass them on to organizations that can maybe help them?
Right. So some of the refugees, yeah, we have collaborated. Definitely, we're in partnership with, for instance, the Somali Women and Children's Association. They're very helpful. We normally go in. From them, we actually get food hampers. So when we see a family like that, we let them know that we're going to do a visit and they'll get something ready for us. So we take food hampers. If there are any other needs, we pass them on and they're able to then also, get some more supports. We also work close with the Catholic Social Services. That's really good. It supports the refugees and I think most times it's a backlog. They're trying to sort their issues out. There are multiple issues. These people are coming from another country. They have medical needs, social needs, and so they're kind of in the queue somewhere, right? But we definitely refer them on when we see such things happening. One of the things we also do is work with the HomeCare, the Alberta Health Services HomeCare. When we find that we go into a home and the senior is struggling to move, mobility is an issue, we make referrals to Alberta Health Services HomeCare.
I mean, with your vast experience in New Zealand, South Africa, I think you've talked enough right here in Edmonton with your business in being able to offer this service, what you do really to seniors who have mobility problems and people who maybe cannot afford, they cannot even transport themselves to their local GP. How did you come across this amazing idea? What did you see?
I think so. There's so many factors. So having worked in countries like Australia, for instance, home visits are is something that happens. We lived in Melbourne, and they do home visits for people who cannot access care. So that's one of the things that sort of led us to start this company, is what was happening in other places and how well they were doing, where you didn't have people who had medical issues, but also social issues. Those people didn't have to somehow struggle to go to a hospital or after hours, because we know most clinics close at 5. And so people are then forced to go to the hospital or to the after hours care. So when we started, this was last year, the pandemic had also hit and most clinics were closing early. And there were outbreaks, hitting the hospitals. So we thought to ourselves, or I thought to myself, we can't be having people who are, first of all, seniors or old or have multiple medical issues go to the hospital, find a cab to go to the hospital to sit and wait for hours and hours, be exposed to COVID because there's a lot of COVID in the hospitals, or be told to wait for hours on end. So there was a gap right there. We thought this was very timely when we started this. We initially thought, okay, well, let's give after hours care to people who cannot move, who don't have transportation, who are senior. But when COVID came, it was apparent that this was a very much needed service.
Mm. Mm. Thank you, Dr. Jennifer. I'm wondering how important is education and poverty to accessing care here in Edmonton? Do you find that your your client, what do you call your patients?
Clients. Clients, and then they become patients, but clients can also work.
Do you find that they are, I don't know, in terms of their levels of education, how important is the education and their streams of poverty in accessing the care you provide?
From a public health perspective, education is one of the determinants of health, right? And so education is key. So we find that most of our newcomers, the refugee population in particular, they're lacking in terms of education. Then there's a health literacy component. So you don't have the formal training, but then you also lack the health literacy. And then the biggest problem is the language and culture. That is so big. So you find that some of these people, they work really hard and they would go access services. But when they get there, language and culture, big barriers. So one of the stories I like to tell, I think I always tell, was of a mom. Again, she has 10 children. She's expecting. And, we went into the home and we looked at the home and we thought, these 10 children, she's having another one coming, but they're living the way they are. As she thought about family planning, she thought about, has someone introduced that idea to her? Now, she wasn't English speaking. English for her is probably a second, third language. So because our team is diverse, that's one of the things you might touch on. Our team is quite diverse. We have a Somali nurse. Our Somali nurse was able to talk to her and say, you're a young woman, you have all these children. Have you thought about family planning? She said, oh, yes, I didn't want to get pregnant this time around. The last time I had a baby, I actually asked the doctor, they something I can have to stop me from having babies. Now, this was probably missed by that doctor who's English speaking. So she had done her bit. She had expressed concern about having many children. She's in a new country. There is poverty of some sort. They have a low income and a low income bracket. She wanted to stop, but how was she going to get that across to a Canadian English doctor?
So it's kind of important that the doctors look a little bit like us, right? If you're Somali, you probably feel most comfortable with a Somali doctor. I'm just saying, it's maybe to understand, because this is an extreme desperate 10 children.
Yeah. And now that would be the best idea, but how many do we have? How many Somali practitioners do we have? So then we need to think we don't have enough people who look like us in the system. Now, Alberta Health Services has a lovely solution. They have a language line, right? But even the language line has its difficulties. So you're sitting with a patient, you're calling into Alberta Health Services to be connected to the language line so you can have this three-way conversation with the person sitting in front of you. Things like contraception are very, very personal, right? It's like you're having somebody else in the room. Hopefully it's a woman, it might be a man, talking to you or with you about something that's very personal. So they find it very intrusive that although this line is there, they're grateful, they can talk about the cough or the backache. But when it comes to women's health and other personal issues, how comfortable would you feel to have language line or someone on the other side of the phone?
Even if the doctor is Yoruba Nigerian, he'll still be happy.
Exactly.
Normal day is hard. It's hard.
It is very difficult. So those are some of the challenges we're really, identifying in the community.
I love doctors. You guys are heroes. I wouldn't even be able to sleep. When I was growing up, I had the option of either doing education or social work. I'm happy I didn't go into social work because it's really intense. What you do is it never ends, And really thankful for your work and doctors and practitioners like yourself. So what are some of the myths coming on to COVID-19 now? What are the most common myths about COVID-19 that physicians should dispel, or that you hear around and this is not true, or that you work at to dispel in your work?
Well, I guess because this is very new, most of the myths we're hearing, we're not really hearing myths. We're hearing actually fear. The fear is mainly what's out there is that, first and foremost, and we can go to that, whether this vaccine will come, whether we're going to get this vaccine. There was a start of, at the very beginning, there was the whole masking, and we're grateful that here in Canada, people are more receptive and they kind of listen and they're able to wear masks. I know in places like the States where you have movements of people who don't believe in wearing masks and don't want to be told what to do. We're lucky we don't have a lot of those kind of people here. So I find that in Canada, people really listen to what they're told and they pull the line. Right. So there's this fear. There's a fear that, is this the end of the world? We heard a lot about that. Is the world coming to an end? Are we all going to catch COVID at the end of the day? Do these vaccines really work? And now we're hearing a lot when you talk about myths, it's more around the vaccines. Unfortunately, the vaccines have come and there's a fear about having the vaccines. Some of the things we heard from some of the refugee families was that the vaccines are sort of, the disease was sort of brought about to kill off the elderly, senior. So I've heard a lot of people who are not Western. And then there's, no, won't take this vaccine because, again, it will have repercussions. The fears are about giving birth. there's this fear about if you take the vaccine, you may not be able to have children as a woman. Now, I don't know where all this is coming from, and of course, it's founded on fear, right? The female, you shouldn't take it. As and some people say religiously they're not going to take the vaccines. There's some people who actually do not, and the health workers who actually do not take the vaccine. Even the flu, influenza, the seasonal influenza vaccine, they don't have them. They don't get their yearly flu shot. So there is that fear that, it goes against our culture, it goes against our religion. It's another thing that's been made, it's been created. The vaccine has come about very quickly. Most vaccines go through several trials. This one has come really fast. Is it genuine? Am I going to have terrible side effects down the line? Unfortunately, there's no data, right? So we're going with faith. You're going to be injected, and hopefully things will be okay. And we don't know what the long-term effects are. If you catch COVID, or if you have the COVID vaccine, what are the long-term effects, right? But we know that with the vaccine, with Pfizer, which is a renowned company, it's done all its research as best as they could, right? And they'll produce this vaccine, right? But there's a lot of fear. There's some pushback about having the vaccine.
Now, I'm just wondering, in terms of what you do, how much of your time do you spend dispelling or fighting all these conspiracy theories? Has it gotten to a stage where it hampers or hinders your work?
Yeah. So when we do the vaccine, so one of the third services we offer, we give the flu shots, and we also give the pneumonia vaccine for people who are seniors, 65 years old and above, or people who have immunosuppression. They may have lung issues, or they might be diabetics, or they might have any kind of sort of immunosuppressive disease. So we give the pneumovax, which is a pneumococcal vaccine. Now, when we go out to give the vaccines, people are grateful. Thank you for giving me my flu shot or my pneumococcal vaccine, but when will you come back to give the COVID vaccine? Right? When am I going to have that? And tell me about this COVID vaccine. Is it safe? Have they tested it? And then they'll say, we've had lots of things happening about with the COVID vaccine. We've had people who've had seizures. We've had people who have died from the vaccine. We've had people who have become very sick, right? All these questions are thrown to us constantly, and I know, like, there were a few cases of people who, there was a lady who died having had the vaccine, but she had other underlying medical issues, right? But no one looks into that. We're looking at COVID vaccine has come, given to her, she passed, right? So now there's that pushback with the vaccine. There's, yes, the vaccine is here, but I don't think I should get it. Is it safe? It came around so quickly. Is it a political gimmick? Is it a political thing? So those are the questions we're now being faced with.
Okay, I've got one for you, Dr. Jennifer. Have you been vaccinated yourself?
So we've started getting vaccinated on our team. Our nurse who actually does the flu vaccines, she's had her vaccines. So the rest of us are sort of in a queue to get ours. As you know, that the vaccines were given first to people who work in ICU and in seniors care, and then we're next on that list as community providers. So they're starting to get to us now.
Okay, well, you'll have no problem getting the vaccine yourself as a frontline healthcare worker.
As a frontline, I would think, I'll weigh the pros and cons, right? I'll look at having that COVID, the disease with all the, the complications, or having this vaccine. So I will go for the vaccine, definitely.
I suppose that's all the confidence and peace of mind little people like us need.
Again, there's no data, right? People ask, it's not like the flu shot. Oh, and people say to you, 2 years ago when I had the flu shot, or 3 years ago this happened. This is all brand new. This is very new.
Does it scare you though? Does it terrify you that Alberta, Canada, has a special problem in that there's generally no data for Black people? So generally. Now we put COVID, you add a layer of COVID onto that, and it's more, what are your thoughts? It's even more difficult to find out how the pandemic is affecting Black people, will affect Black people. or even the vaccine will affect Black people. And a lot of Black people, a lot of us have underlining, it's not a curse or anything, but it's just the way life.
Well, yeah, I guess it is concerning that I think for everybody really, I don't know, the data will start to be collected, but I do understand and I acknowledge the fact that with Black people, we we tend to not have, there's no data for us. But one of the things I'm a part of is the Alberta Health Coalition and also the Alberta Health Services Refugee Health Partners. And that's one of the things they're discussing now is the refugees and how COVID has affected the refugee population. So I think Alberta Health Services, maybe through the advocacy, through some of the work you're doing, Tees, through some of the work that other people are doing in the space, I think people in places are hearing us. I think people are hearing us. People, Alberta Health Services are hearing us that it is important to collect this data. And when I go into the meetings and I attend the committee meetings, I bring back the feedback, from the refugee committees and either the community, and they're listening and they're actually listening to us. So I think for us, what I always think is us being represented in those spaces. Alberta Health Services needs to hear us. Alberta Health has to hear what we're saying so that we can get our data collected.
You alluded earlier to the fact that there are not as many Black or BIPOC professionals with Alberta Health Services. And are you, okay, this is my question. Are we saying here that the few BIPOC professionals with Alberta Health can change, or until maybe we have a BIPOC health minister and we can really push in the changes we would like to see? Are we going to see any change at all? Is that the path we're on or not?
I'm hoping that's the path we're on. And I think there's a lot of work. I think if collective work that we're doing, the work that you're doing, the work that is some of the people in the group, I know we have a group, Women Talk, and I see some of the ladies there involved with the anti-racism committee or group there. So I think if we do all this work collectively, our voices will be heard. But Rome wasn't built overnight, right? Rome wasn't built overnight. But I think we need to be a bit more active than we are. That's my impression coming into Canada, into Alberta. I've been here for 4 years, and I feel we're very passive. And if we remain passive, the status quo remain, right? We need to be a bit more active, push our agenda. We try and get onto those tables, those decision-making tables. We need to do that.
Dr. Jennifer, what more can we do? Please tell us with your outsider, insider eyes. Because I have friends who are doctors and they're cab drivers also in this city. I have a friend, she got pregnant. Oh, God bless her. But she's still trying even to practice. And they sometimes make it hard. And her husband is saying she's got to find something else. That kind of pressure. That's what happens to Black people, regardless of where you come from. So you may have a good, decent degree from the UK. You say, no, it's got to be Alberta. You know what? These blocks are real. And what was my question? What more do we need to do?
See, it's an ongoing thing. I don't think we can solve it overnight. But our director of health services, Angela, and I, we're always talking about this, and I say to her that it is tiring for me, optically, to go into these meetings and to be part of these groups. And I look around the table, and I'm the only person of color. I mean, there might be an Indian, maybe, or a Chinese, but I always say I've just come to this country, to this province. Where are the educated people, the educated Black people? Why are they not part of this? So why is it that we put a lot of effort and we have all these lovely groups, but we're sort of functioning on the periphery, right? We're not front and center. How do we get ourselves involved and how do we get ourselves on these tables? I wasn't invited. I would tell you, T, I wasn't invited to the table. I invited myself. I did. I invited myself, and they weren't going to say no. I don't think they're going to say no. But I think if more of us are like that, they'll start to hear us.
yeah, maybe more of us are not as educated as you. You know, we've all not been to. You know, you guys are the richest. You're like the Della cream at the top, and the rest of us are just here at the bottom. The doctors are at the top of any kind of ladder in any kind of society. So, but I think with you is the desire and the willingness to engage, which is absolutely, which is brilliant, and we thank you for the advocacy you give to us. But most people wanna, but you know, people like us are not even funded, so and we're barely seen, you know. So
And I
it's
guess,
hard.
yeah. And I guess the doctor's also working because I went into public health. I was working in a clinic before. This is in New Zealand. And I used to work in a clinic and you know, you'd get so frustrated seeing things. And I remember saying to my group and said to them, you know what? I am tired of complaining as a foot soldier. I'm going to go and be part of the decision makers. So I marched into the Alberta Health Services equivalent of the city Auckland where we live. And I said, okay, I'm looking for a position here where I can bring the voices of people on the ground for you guys to listen to. And
Mm.
that was in maternal child health area. And I went into public health and I started cutting down my clinic hours. And that's where I went. I was part of various groups that represent, you know, the Ministry of Health and all sorts of things. But I pushed my way through because I thought I'm done with talking about it in our little circles and complaining. I'm going to go up there. The doctors are busy. There are lots of educated people here. And you know, they've got lots of patients, they're seeing patients, lawyers are busy, engineers are busy, lots of educated people in this city. They're very busy. But so I guess it just takes the whole, okay, let me cut out some time. I know I don't have time. Let me cut out some time and maybe go meet up with some of these decision makers and make some noise, you know, because we need to keep pushing. This is not going to change overnight. We need to be pushing.
Yeah, I mean, one of the problems I can see, 2 points, maybe 5 months in this city as well. And I suppose the problem is, what do I do? Where do I go? Who do
Mm.
I talk to? How do I even say these things? Because you must be pretty brave, but if you are the only black person in the city, I can imagine middle-aged white man, and you're still able to compose yourself and talk. That's pretty, oh my God, impressive. But most of us, I don't know, probably be at home feeding Jimmy, you know.
Yeah, I don't know. I think I'm just a troublemaker, but I'm one for I can't take this anymore. That kind of a person. I'm not taking this anymore. I'm going to talk to Africa Center. So we went and you know we worked up with Africa Center. We formed a partnership there. I'm going to go to the HIV Edmonton. We formed a partnership there. They could hear us. You know, the Somali Women and Children's Association, we just gave them a call and we had an appointment with the CEO. They were going to talk to you about this, find out, you know, what the issues are, how can we work with you. So I'm not one to sit back, I'm one to push. And I know people are busy and life is busy. You've got family, you've got so many things going on, but I think we need to keep pushing. We need to keep pushing and make it our agenda. Somewhere on our busy plate, we all have plates are so full. We need to somehow make it one of our priorities. Otherwise, they won't hear us. They
Okay.
won't hear us.
Okay, so I've got two more questions for you, maybe even three. We'll just quickly, and I know there's no such thing as a quick question. So, what do you say to someone listening or watching this and saying, yeah, it's easy for you to say you are rich, and most doctors are just spoiled anyway. It's easy for you to tell the rest of us to march, you know. What would you say to that person?
I would say even where you are, you can make a difference.
Mm,
And there are lots of opportunities here. And I think for me, I think it's just getting to know where those opportunities are and how you can make a difference.
yeah.
But there's something you can do even in your own community. You can start something. You can start that noise. And before you know it, people are hearing it from miles away.
Okay.
Yeah.
How bad is mental health in our communities? I hear because of the pandemic, it's on a decline. Is it bad? Am I making this up? What do you see when you go about?
Yeah, so it is bad. People, so I'll talk about the seniors first and foremost. They have been alone. There's a lot of isolation. They haven't seen their family members for months and months. So that alone is enough, you know, to depress somebody. So there's that isolation. And then there's a whole losing of your livelihood. If you're working in a job and you're laid off, made redundant, there's that too. You've got to pay the bills, and you have to make ends meet. You might be having a business that has gone under because of COVID or is going under. So that alone is enough to stress you to a point that things start to be unbalanced for you. Right, you start to get out of balance, and before you know it, you're suffering from some kind of mental illness. So it is bad now with the COVID, absolutely.
Thank you very much, Dr. Jennifer. And my final question, I think, is where do we find you, and how expensive is it to get a doctor like you into Chappelle to come and take care of us? Or do you go around the city, or do you just go to the west?
We cover the whole of Edmonton, so it's just a phone call for us. Give us a call, and we'll schedule someone to come and see you. If you're an Alberta resident, again, you don't have to pay. The government pays us, so the services are free for you as the person receiving them. The donations. So you just have to pick that phone up and call us and tell us what the issue is, and after hours, we come and provide you that service.
Okay. Dr. Jennifer, we've taken enough of your time. I want to say thank you so much for your for the frank discussion we've had here today. And I believe people hearing will be spurred to call your number, to invite you to get our communities moving in the right direction. Your website is being displayed as CanadaHomeCareGroup.ca, and we can call you and you come out to support us. Thank you again for coming on to the show tonight. Thank you.
Thank you for the opportunity, T. It was a lovely discussion, and hope we can meet again after COVID for Kappa.
Absolutely.
Oh, yes, at the end of this all. Absolutely.
Dr. Jennifer, you went right there. I'm going to end the live broadcast. Thank you, everybody. See you next time. But Dr. Jennifer, just one quick minute.